Welcome to Quick Medical Review, the podcast where we make complex medical topics simple, high yield, and exam ready. Today we're covering atrial fibrillation, the most common sustained cardiac arrhythmia, and a topic that comes up repeatedly across USMLE, MRCP, PLAB, and SMLE. Let's get into it. Normally, the sinoatrial node in the right atrium generates organized electrical activity that coordinates atrial contraction. In atrial fibrillation, disorganized electrical activity overrides the SA node, causing rapid, chaotic atrial contraction. On an ECG, this produces three hallmark findings, and you must know these: absent P waves, an irregularly irregular ventricular rhythm, and a narrow QRS complex tachycardia. Because the atria are fibrillating rather than contracting properly, blood stagnates particularly in the left atrial appendage. This creates a prothrombotic environment and is the reason AF significantly increases the risk of ischemic stroke. The ventricles fill inefficiently during diastole, which reduces cardiac output and can lead to heart failure over time. This is known as tachycardia-induced cardiomyopathy. There are several clinical patterns of AF, and examiners love testing these. Paroxysmal AF episodes that terminate spontaneously within 7 days, usually within 48 hours. Persistent AF lasts longer than 7 days and requires intervention to restore sinus rhythm. Long-standing persistent continuous AF for more than 12 months, where rhythm control is still being pursued. Permanent AF, a clinical decision has been made to stop attempting rhythm control. Also distinguish between valvular and non-valvular AF. Valvular AF is defined as AF occurring with moderate to severe mitral stenosis or a mechanical heart valve. Remember the mnemonic Smith for the most common causes: S for sepsis, M for mitral valve disease, I for ischemic heart disease, T for thyrotoxicosis, and H for hypertension. Other important associations include alcohol excess, sometimes called holiday heart syndrome, pulmonary embolism, post-cardiac surgery, and obstructive sleep apnea. Many patients are asymptomatic, with AF detected incidentally during a routine pulse check or ECG. When symptomatic, patients may report palpitations, breathlessness, dizziness, or fatigue. Some present with complications, particularly stroke or heart failure. Example: the two causes of an irregularly irregular pulse are atrial fibrillation and multiple ventricular ectopics. The key distinction is that ventricular ectopics tend to disappear at higher heart rates, so if the rhythm becomes regular during exercise, think ectopics rather than AF. Treatment of AF has two fundamental pillars: rate or rhythm control, and anticoagulation for stroke prevention. Starting with rate versus rhythm control, the 2024 ESC guidelines and the NICE 2021 update recommend rate control as first line for most patients. Rate control aims to keep the ventricular rate below 110 beats per minute at rest. First line for rate control is a beta blocker. Bisoprolol is the most commonly used. Second line is a rate-limiting calcium channel blocker like diltiazem, but avoid this in heart failure with reduced ejection fraction. Digoxin is reserved for sedentary patients or as add-on therapy. Rhythm control returning to sinus rhythm is preferred when there is a reversible cause. AF is new onset within 48 hours. The AF is causing heart failure, or the patient remains symptomatic despite adequate rate control. Cardioversion can be pharmacological or electrical. If AF onset is less than 48 hours, cardioversion can proceed immediately. If AF has been present for more than 48 hours, anticoagulate for at least 3 weeks before attempting cardioversion, or perform a transoesophageal echocardiogram to exclude left atrial thrombus. For pharmacological cardioversion, flecainide is first line in structurally normal hearts. Amiodarone is preferred in patients with structural heart disease. For electrical cardioversion, sedation is given and synchronized DC shocks are delivered. After successful cardioversion, long-term rhythm maintenance options include beta blockers first line, dronedarone second line, and amiodarone for patients with heart failure or LV dysfunction. For paroxysmal AF, a pill-in-the-pocket approach with flecainide can be used in selected patients who have infrequent episodes, no structural heart disease, and can reliably identify their symptoms. The second pillar is stroke prevention through anticoagulation. Use the CHA2DS2-VASc score to assess stroke risk. This is a mnemonic: C for congestive heart failure, H for hypertension, A2 for age 75 or above scoring 2 points, D for diabetes, S2 for prior stroke or thanks in advance scoring 2 points, V for vascular disease, A for age 65 to 74, and S for sex female sex scores 1 point. A score of 0 means no anticoagulation needed. A score of 1 means consider anticoagulation. A score of 2 or more means anticoagulation should be offered. Direct oral anticoagulants or DOACs are now first line over warfarin for non-valvular AF. Options include apixaban, rivaroxaban, edoxaban, and dabigatran. They require no routine monitoring, have fewer drug interactions, and have a more predictable dose response compared to warfarin. Warfarin remains the drug of choice for valvular AF, specifically with mechanical heart valves or moderate to severe mitral stenosis. Target INR is 2 to 3. Importantly, aspirin has no role in stroke prevention in AF. This was removed from guidelines years ago. The HAS-BLED score assesses bleeding risk and helps guide shared decision-making. Generally, the stroke risk outweighs the bleeding risk in most patients. Rapid-fire summary. ECG findings: absent P waves, irregular rhythm, narrow QRS. Most common causes: remember Smith sepsis, mitral valve, ischemic heart disease, thyrotoxicosis, hypertension. Rate control first line, beta blocker. Rhythm control indications: reversible cause, new onset under 48 hours, causing heart failure, symptomatic despite rate control. Cardioversion rule: anticoagulate 3 weeks before if AF over 48 hours. Flecainide: avoid in structural heart disease and atrial flutter. Stroke risk: CHA2DS2-VASc score. Anticoagulation first line: DOACs for non-valvular AF. Warfarin for mechanical valves and moderate severe mitral stenosis. No aspirin for AF stroke prevention. Irregular differential: AF versus ventricular ectopics. That's your complete review of atrial fibrillation. Study smart, not hard. If you found this episode useful, subscribe, leave a review, and share it with your study group. This has been Quick Medical Review. See you in the next episode.